Welcome to Chapter 8 of the Cornea BCSC. In this chapter, we'll explore corneal dystrophies, a diverse group of inherited, non-inflammatory disorders characterized by progressive changes in corneal structure that can impact vision. We'll review their clinical presentations, pathological findings, and distinguishing features that help differentiate one dystrophy from another. Importantly, we'll also cover management strategies, from conservative approaches to advanced surgical techniques, and highlight how recurrence patterns influence long-term outcomes. Let's get started.
We will begin with a general overview of the typical features of corneal dystrophies. These conditions are bilateral and usually symmetrical, although occasional asymmetry can occur. They are generally inherited with minimal environmental or systemic association. An exception is epithelial basement membrane dystrophy, or EBMD, which may not be inherited. Corneal dystrophies are often detected early in life. They tend to have a slow progression and may remain asymptomatic until later. Many arise from genetic mutations, such as changes in the TGFBI gene, leading to aberrant protein deposition. For example, keratoepithelin deposition in the anterior stroma. Some dystrophies can cause recurrent corneal erosions, especially when the epithelial basement membrane or Bowman layer is involved. Common symptoms include blurred vision due to irregular astigmatism, stromal opacity, or corneal edema. The International Committee for the Classification of Corneal Dystrophies, ICD-3, revised the nomenclature to more accurately reflect the evolving genetic, clinical, and histologic characteristics of the dystrophies. In this reclassification, updated in 2015, the corneal dystrophies are classified into four main categories: epithelial and subepithelial dystrophies, epithelial stromal TGFBI dystrophies, stromal dystrophies, and endothelial dystrophies.
Let's review the major corneal dystrophies, organized according to the IC3D classification system. We'll start with the epithelial and subepithelial dystrophies. These include epithelial basement membrane dystrophy, which may also have degenerative features, Meesmann epithelial corneal dystrophy, gelatinous drop-like corneal dystrophy, epithelial recurrent erosion dystrophies, Lisch epithelial corneal dystrophy, and subepithelial mucinous corneal dystrophy. Next are the epithelial stromal dystrophies, which are associated with mutations in the TGFBI gene. This group includes Reese-Buckler's corneal dystrophy, Thiel-Behnke corneal dystrophy, lattice corneal dystrophy with several variants, and granular corneal dystrophy types 1 and 2. These are the TGFBI-related dystrophies, and they are the most strongly associated with recurrent corneal erosions. Moving on to the stromal dystrophies. This category includes macular corneal dystrophy, Schneider corneal dystrophy, congenital stromal corneal dystrophy, Fleck corneal dystrophy, posterior amorphous corneal dystrophy, and predecimate corneal dystrophy. Finally, the endothelial dystrophies. These include Fuchs endothelial corneal dystrophy, posterior polymorphous corneal dystrophy, and congenital hereditary endothelial dystrophy. Altogether, this classification provides a systematic framework for understanding the wide range of corneal dystrophies and highlights the importance of recognizing their clinical and genetic features. When approaching a patient with a suspected corneal dystrophy, it is important to ask several key questions that help with diagnosis and differentiation. First, consider the family history. Are other relatives affected? Because most dystrophies are inherited, this can be a critical clue. Next, evaluate for inflammation. Ask if there is redness, inflammatory cells in the anterior chamber, or any neovascularization. If these are present, it often suggests the condition is not a dystrophy. Think about laterality. Are opacities present in both eyes? Dystrophies are usually bilateral, though sometimes they may be asymmetrical. The location of the opacity is also essential. Determine which corneal layers are involved: epithelial, stromal, or endothelial. Assess the lesion borders. Are there clear zones between the lesions? Many dystrophies show distinct separation between deposits, though these zones may become less obvious with aging. Consider the extent of the lesions. Most dystrophies do not reach the limbus, with the key exception being macular corneal dystrophy, which does. Look at corneal thickness. Is it abnormally thick, thin, or within normal limits? Finally, evaluate the lesion morphology. Does the appearance match what is typical for a specific dystrophy? These systematic questions can help differentiate dystrophic conditions from degenerative, inflammatory, or acquired processes. We will now begin our discussion on the first group of corneal dystrophies, which involve the epithelial and subepithelial layers. We begin with epithelial basement membrane dystrophy, or EBMD. This condition is also known as MAP.fingerprint dystrophy, anterior basement membrane dystrophy, or Cogan microcystic epithelial dystrophy. There is no confirmed inheritance pattern, and it may be considered a degenerative change. EBMD is fairly common, affecting about 6 to 18% of the U.S. population, and is more frequent in women and in individuals over the age of 50. There are 4 characteristic epithelial patterns. The MAP pattern presents as a geographic, irregular gray haze with scalloped borders. The fingerprint lines appear as thin, parallel hairline lines in concentric patterns, resembling a fingerprint or horse's tail. The dot pattern is made up of irregular intraepithelial opacities from degenerated epithelial cells. And finally, the bleb pattern gives a pebbled glass appearance. These changes are best seen with a broad oblique slit lamp beam using retroillumination or with sclerotic scatter. It's important to note that these patterns may occur in combination within the same patient, and they can change over time. Let's now look at the characteristic patterns of EBMD. On the left image, we see the fingerprint lines pattern. These appear as fine, parallel hairline streaks resembling a fingerprint or a horse's tail. They are best visualized with retroillumination, where the reflected light highlights the subtle linear changes within the epithelium. The middle image demonstrates the MAP pattern, with broad, irregular, grayish opacities that have scalloped borders. Here, they are shown using sclerotic scatter, which enhances their geographic appearance against the dark background. Finally, the right image highlights the dot pattern. These are irregular intraepithelial opacities, often appearing as small, putty gray deposits. In this case, arrows point to the geographic areas and scattered dots that characterize this presentation. Together, these images illustrate the maps, dots, and fingerprint lines that give EBMD its classic alternative name of MAP.fingerprint dystrophy. Let's now review the symptoms and exam findings in EBMD. Patients often experience recurrent epithelial erosions, which are especially common in individuals over the age of 30. Symptoms include blurred vision, ghosting, and monocular diplopia. The degree of visual disturbance depends on how close the surface disruption lies to the visual axis. Many patients report morning discomfort, which can be worse in those with nocturnal lag ophthalmos. Additionally, inferior corneal punctate erosions may also be present. On exam, you may observe the characteristic epithelial patterns, MAP, dot, and fingerprint changes. The corneal surface often shows irregularity, demonstrated by negative fluorescein staining. This surface irregularity can lead to irregular astigmatism, noted as distorted mires on keratometry or irregular rings on placido imaging. It is estimated that about 10% of patients with EBMD will develop erosions, and conversely, 50% of patients with recurrent erosions will have EBMD. Therefore, it is always important to examine the fellow eye for signs of this condition. Keep in mind that unilateral changes may be due to trauma, but EBMD can sometimes mimic intraepithelial dysplasia. In uncertain cases, histology may be required for confirmation. Furthering the discussion on the clinical signs of EBMD, in Image A, we see the cornea illuminated with a broad, oblique slit lamp beam. Here, the characteristic map-like pattern is visible as irregular geographic opacities that is accentuated with retroillumination. Image B demonstrates the same condition after installation of fluorescein dye. The irregularities of the epithelial surface become more easily identifiable, showing areas of negative staining where the dye does not pool. Finally, in image C, keratometry reveals irregular mires highlighted within the central 3 mm. This finding indicates the presence of irregular astigmatism, which directly correlates with the visual symptoms reported by patients. In this example, inferotemporal irregularity of the mires corresponds with superotemporal EBMD. The underlying pathology of EBMD involves abnormal epithelial turnover, maturation, and basement membrane production. On histology, several distinct features may be identified. First, sheets of intraepithelial multilamellar basal lamina correspond clinically to the map pattern. Fingerprint lines are caused by the basal lamina extending into the epithelium. Intraepithelial pseudocysts containing cytoplasmic debris are also observed and account for the dot pattern. Additionally, irregular subepithelial fibrogranular deposits may be found, which present clinically as the bleb pattern. Management of EBMD is based on the patient's symptoms. Those who are asymptomatic do not require treatment. In patients with irregular astigmatism or blurred vision, epithelial debridement may help to improve the surface. For individuals suffering from recurrent erosions, initial medical therapy includes hypertonic sodium chloride ointment or drops, bandage contact lenses, and nighttime protective shields. If conservative therapy fails, surgical options may be considered. These include epithelial debridement, anterior stromal puncture, or PTK. Meesmann epithelial corneal dystrophy, or MECD, is an autosomal dominant condition. A notable variant, called the Stalker-Holt variant, presents with earlier onset and more severe signs and symptoms, and is often identified through genetic testing. Clinically, this condition is characterized by tiny intraepithelial vesicles that resemble bubble-like blebs extending across the epithelium, often reaching the limbus. These lesions usually have a clear surrounding zone. Onset occurs very early in life, and about 85% of cases are bilateral. The cornea may appear slightly thinned, and corneal sensation can be reduced. Patients may report mild irritation, glare, decreased vision, and in some cases recurrent painful erosions. Pathologically, MECD shows intraepithelial cysts containing degenerating cellular products that stain positive with PAS. There may be accumulation of fibrogranular material, cytoplasmic filaments, and thickening of the basement membrane. On confocal microscopy, the basal epithelial layer shows hyporeflective areas that may be accompanied by scattered hyperreflective spots. Management is typically conservative. In most cases, no treatment is required. Symptomatic patients may benefit from lubrication or the use of soft contact lenses to relieve discomfort. In the accompanying slit lamp image, you can see the multiple, fine, bubble-like epithelial vesicles scattered across the corneal surface, giving the cornea a stipid appearance under illumination. Gelatinous drop-like corneal dystrophy, or GDLD, is an autosomal recessive condition that typically presents in the first or second decade of life. Clinically, it is characterized by the development of small nodules, often described as having a mulberry-like appearance, as shown in image A. In some cases, these lesions resemble band keratopathy, like opacities, as seen in image B, while in more advanced stages, patients may develop larger kumquat-like nodules, shown in image C. Over time, superficial vascularization and progressive stromal opacification occur, leading to worsening symptoms. Patients commonly experience reduced vision, photophobia, irritation, and tearing. Pathologically, GDLD is associated with subepithelial and stromal amyloid deposits, which increase epithelial permeability. These amyloid deposits can be identified on confocal microscopy or transmission electron microscopy. Management is challenging. Superficial keratectomy, lamellar keratoplasty, or full keratoplasty can be performed, but unfortunately, there is a high rate of recurrence. The use of soft contact lenses has been shown to help reduce recurrence and provide symptomatic relief. The accompanying images illustrate the range of clinical findings, from early mulberry-like nodules to advanced kumquat-like lesions, highlighting the progressive and visually significant nature of this disorder. Next, we'll talk about epithelial stromal TGF-beta1 dystrophies. Reese-Buckler's corneal dystrophy, or RBCD, is an autosomal dominant condition that typically presents within the first few years of life. Clinically, it is marked by confluent, irregular, coarse, geographic opacities that form over the central cornea, primarily involving Bowman's layer and the superficial stroma. As the condition progresses, these opacities may extend toward the limbus and deeper stroma layers, though the posterior cornea remains unaffected. Patients often develop painful, recurrent erosions at an early age, which may begin in the first or second decade of life. These erosions are associated with surface irregularity and progressive vision reduction due to the disruption of corneal clarity and smoothness. Because of this, patients frequently experience significant visual symptoms alongside discomfort. Importantly, RBCD tends to be more severe than Thiel-Behnke dystrophy, both in terms of symptom burden and clinical progression. The images here illustrate the characteristic appearance of RBCD, with central corneal opacities that create a rough, geographic pattern, disrupting the normal corneal architecture. Here we review Reese-Buckler's corneal dystrophy pathology. Light microscopy shows disruption or absence of the Bowman layer, which is replaced by sheet-like connective tissue or hyaline, highlighted in red on the stain to the right. Granular deposits in this condition stain red with a Masson trichrome stain. On transmission electron microscopy, subepithelial, electron-dense, rod-shaped bodies can be identified, and these are TGFBI positive. Confocal microscopy demonstrates hyperreflective granular deposits within the basal epithelium and Bowman layer. Management focuses on reducing recurrent erosions, often using superficial keratectomy, phototherapeutic keratectomy, or lamellar keratectomy. In severe cases, deep anterior lamellar keratoplasty or penetrating keratoplasty may be required, although recurrence in grafts is common. Thiel-Behnke corneal dystrophy is an autosomal dominant disorder that typically begins in the first to second decade of life. The condition often starts as solitary flecks at Bowman's layer, which gradually progress into symmetric subepithelial reticular opacities, arranged in a characteristic honeycomb pattern. Importantly, these lesions generally spare the corneal periphery, though over time they can extend into the deeper stroma and periphery. Clinically, patients may develop recurrent corneal erosions, though these tend to be less frequent and less severe than in Reese-Buckler's dystrophy. Visual loss occurs more gradually, primarily as a result of progressive corneal opacification. Distinguishing Thiel-Behnke dystrophy from Reese-Buckler's can be challenging, but advanced imaging with OCT and confocal microscopy can be helpful. One key difference is that recurrent corneal erosions are much more common in Reese-Buckler's dystrophy compared to Thiel-Behnke. Pathologically, ASOCT shows a hyperreflective Bowman layer with a sawtooth or wavy configuration, which helps distinguish Thiel-Behnke from Reese-Buckler's. Light microscopy demonstrates irregular thickening and thinning of the epithelium, with ridges and furrows extending into the underlying stroma. The Bowman layer is replaced by fibrocellular material in a sawtooth pattern. On electron microscopy, curly fibers measuring 9 to 15 nanometers, which are TGF-beta1 positive, differentiate Thiel-Behnke from Reese-Buckler's, which shows rod-shaped bodies instead. Confocal microscopy reveals reflective deposits in both the epithelium and Bowman layer, though these are less intense than those seen in Reese-Buckler's. Similar to Reese-Buckler's and the other corneal dystrophies coming up in future slides, management includes SK, PTK, LK, DALK, and PKP. Now let's take a closer look at the key differences between Reese-Buckler's and Thiel-Behnke. Regarding corneal erosions, Reese-Buckler's tends to present with erosions that are more frequent and more severe. In contrast, Thiel-Behnke cases usually show erosions that are less frequent and less severe. In appearance, Reese-Buckler's typically displays coarse, irregular geographic opacities. Meanwhile, Thiel-Behnke has a more delicate, symmetric honeycomb pattern, which is a helpful distinguishing feature. On ASOCT, in Reese-Buckler's, the sawtooth pattern is not particularly prominent. However, in Thiel-Behnke, the sawtooth pattern at the Bowman layer is much more distinct and a clear differentiating factor. Under confocal microscopy, Reese-Buchler's is characterized by highly reflective material without shadows. On the other hand, Thiel-Behnke shows moderately reflective material but with shadows. Finally, on transmission electron microscopy, Reese-Buchler's reveals rod-shaped bodies that are immunopositive for TGF-beta1 protein keratoepithelin. In contrast, Thiel-Behnke demonstrates curly fibers, also immunopositive for TGF-beta1, but structurally different from the rod-shaped bodies of Reese-Buchler's. Now we will talk about lattice corneal dystrophy, specifically LCD type 1, the classic form. This condition is inherited in an autosomal dominant pattern and usually presents early, often in the first decade of life. Clinically, it is characterized by refractile branching lines within the corneal stroma, central or subepithelial ovoid white dots, and a diffuse anterior stromal haze. The lines start superficially and centrally, then progress deeper and peripherally over time. The cornea may take on a ground glass appearance, while the periphery is typically spared. Patients often suffer recurrent epithelial erosions from childhood, and vision loss results from stromal haze and surface irregularity, typically by the fourth decade. Variants include type 3A, which has later onset with severe erosions, thick ropey lines, and heavy amyloid, and type 4, which involves the posterior cornea and is less associated with erosions. The differential diagnosis includes crystalline deposits from monoclonal gammopathy, polymorphic amyloid degeneration in older patients, and familial amyloidosis with lattice corneal changes, previously referred to as lattice type 2. Here is an example of lattice variant type 3A. Unlike the classic form, type 3A presents later in life and is associated with much thicker, ropey lattice lines and more severe recurrent erosions. The central stroma often develops dense haze, and retroillumination reveals the striking thick lattice lines extending across the cornea. This variant is characterized by heavy amyloid deposition, leading to more rapid progression and significant visual loss. In lattice corneal dystrophy, the hallmark pathological feature is the presence of arborizing amyloid deposits. These deposits are most prominent in the anterior stroma, but they can also be found subepithelially. This weakens epithelial stromal adhesion, making the cornea prone to recurrent erosions. Histologically, we see an eosinophilic layer between the epithelial basement membrane and Bowman's layer, caused by amyloid deposition. This disrupts the normal stromal lamellar architecture. Amyloid stains help confirm the diagnosis. Congo red will turn the deposits rose to orange red, while crystal violet demonstrates metachromasia. Under polarized light, the amyloid exhibits birefringence with dichroism and an axis shift, which is a diagnostic feature. Electron microscopy shows dense extracellular fibrils about 8 to 10 microns in size, arranged in a random pattern. Confocal microscopy demonstrates linear images, but these must be carefully differentiated from fungal hyphae to avoid misdiagnosis. As you would expect, management includes SK, PTK, LK, DALK, and PKP. Let's take a closer look at the histopathological features and confirmatory imaging of lattice corneal dystrophy. In Figure A, you can see amyloid deposits within the corneal stroma. These deposits stain positively with Congo red dye, which gives them a characteristic red-orange hue under the microscope. Moving to Figure B, when a polarizing filter is applied and rotated, the amyloid deposits demonstrate dichroism. This means the color changes depending on the orientation of light, here shifting from red-orange to apple-green. This birefringence under polarized light is a classic diagnostic clue for amyloid. On the right, in Figure C, we see an in vivo confocal microscopy image. Notice the bright, branching linear structures indicated by the arrows. These correspond directly to the lattice lines observed clinically in the corneal stroma. Confocal imaging is therefore very useful in confirming the diagnosis and correlating it with the clinical picture. Next, let's move on to granular corneal dystrophy type 1, also known as GCD1. This condition follows an autosomal dominant inheritance pattern. In terms of clinical presentation, patients usually present early in life. The hallmark finding is the presence of crumble-like superficial opacities. Under direct illumination, these appear as distinct white opacities, whereas under indirect illumination, they take on a more translucent appearance, with dots and vacuoles that look like crushed breadcrumbs. Initially, the opacities are well separated, but with time, they become confluent. Importantly, they typically do not extend all the way to the limbus, but they can extend anteriorly through the Bowman layer. The disease is slowly progressive. Vision is often preserved into adulthood, but eventually declines as the opacities merge. On average, visual acuity reaches 2200 by around 50 years of age. Clinically, patients may complain of glare, photophobia, recurrent erosions, and gradual vision loss as the opacities coalesce. If you look at the image on the right, you can see this classic breadcrumb-like appearance scattered across the cornea. Histologically, the deposits stain bright red with Mason trichrome, reflecting their hyaline nature. On electron microscopy, they appear as electron-dense rod-shaped bodies in an amorphous matrix. These deposits are non-collagenous proteins originating from epithelial cells or keratocytes. Management again includes SK and PTK in early cases, and LK, DALK, and PKP in advanced cases. Note that PTK can induce a hyperopic shift. Refractive surgeries, such as PRK and LASIK, are contraindicated due to their propensity to worsen corneal opacification. Granular type 2, also known as Avellino dystrophy, is inherited in an autosomal dominant pattern. What makes this condition distinct is that it combines features of both granular and lattice dystrophies. Clinically, patients present with stellate, snowflake-like, and icicle-shaped opacities in the superficial to mid-stroma, along with lattice lines that appear deeper than the snowflake opacities. In older patients, an anterior stromal haze develops between the deposits, which leads to reduced vision. Some individuals also experience mild recurrent corneal erosions, which can sometimes be painful. Pathologically, Avellino dystrophy is characterized by both hyaline deposits, typical of granular dystrophy, and amyloid deposits, typical of lattice dystrophy. These extend from the basal epithelium into the deep stroma and stain positively with Mason trichrome and Congo red. On electron microscopy, both rod-shaped deposits and amyloid fibrils can be identified, confirming the hybrid nature of this condition. Management is similar to type 1 in that LK or PKP may be required for advanced cases, although recurrence is possible in grafts. That finishes up the discussion about TGF-beta1 related conditions. Now we will shift our attention to those dystrophies related to the stroma. Let's first talk about macular corneal dystrophy. Unlike most corneal dystrophies, which are autosomal dominant, macular is inherited in an autosomal recessive pattern, making it unique in this sense. It is rare and involves the entire stroma, including the periphery, and may even extend to the endothelium, which appears as guttae without corneal edema. This condition typically begins in early childhood, between 3 and 9 years of age, and causes progressive clouding. Vision tends to decline significantly by the second or third decade of life. Epithelial erosions are rare in this condition. Clinically, we see whitish flecks in the cornea that evolve into gray-white opacities with intervening haze. Hypoesthesia is common, and diffuse thinning of the cornea is often present. It can mimic interstitial keratitis, but the key distinction is that macular dystrophy does not show ghost vessels or a thickened Descemet's membrane. Here we can see the clinical appearance of MCD. In the early stages, there are only a few central macular opacities. As the condition progresses, the opacities spread throughout the cornea, extending from limbus to limbus. An important point is that not only the opacities themselves, but also the intervening stromal spaces become hazy. This diffuse haze contributes significantly to the vision loss patients experience. This slide really highlights how the disease progresses over time, from focal early changes to widespread corneal clouding.
In macular corneal dystrophy, the underlying pathology is characterized by the deposition and accumulation of glycosaminoglycans, or GAGs, within the endoplasmic reticulum of keratocytes and endothelial cells. These deposits can be demonstrated histologically with special stains such as colloidal iron and alcium blue, both of which highlight the GAG material. On electron microscopy, these changes appear as fibrogranular clumps that specifically stain for glycosaminoglycans. The images shown here illustrate this. On the left, you see the blue staining pattern with alcium blue, and on the right, the greenish deposits are highlighted with colloidal iron. Together, these findings confirm the biochemical nature of the deposits and explain the structural and visual changes seen clinically.
Diagnosing this condition can be supported biochemically through ELISA testing, which measures antigenic keratin sulfate, or AGKS. Based on biochemical findings, 3 distinct variants can be identified. In type 1, the most prevalent form, there is no detectable antigenic keratin sulfate in the cornea, serum, or cartilage. In type 1A, keratocytes stain positively for antigenic keratin sulfate, but the extracellular matrix does not, and serum antigenic keratin sulfate remains absent. In type 2, all deposits stain positively for antigenic keratin sulfate, and serum levels are within a low to normal range. In terms of management, the primary goal is to provide symptom relief and preserve vision. Photophobia can be managed with tinted lenses, while superficial disease may benefit from PTK. For advanced cases, definitive treatment requires DALK or PKP. Fortunately, the prognosis is generally favorable, and recurrence after grafting is rare compared to the others. When we compare the age of onset, the order goes from macular to lattice and then to granular. An easy way to remember this sequence is with the phrase, "my little grandma." This highlights that macular presents earliest, followed by lattice, and finally granular. When it comes to graft recurrence rates, the order shifts. Recurrence is most common with resbucklers, followed by lattice, then granular, and least with macular. The mnemonic here is repeat little grafts more, which mirrors that order. These memory tools make it much easier to keep straight both the timing of onset and the likelihood of recurrence after grafting. Next, we will talk about Schneider corneal dystrophy. This is a rare, slowly progressive disease that can present as early as infancy. It follows an autosomal dominant inheritance pattern and is strongly associated with hypercholesterolemia, seen in about 2/3 of patients. Clinically, diagnosis is often made in the 2nd or 3rd decade. Interestingly, only about half of patients show central subepithelial crystals, which do not involve the epithelium. Because of this, the older term Schneider crystalline dystrophy is no longer recommended. The disease shows progressive age-related changes. Before the age of 23, patients may show ring-like or disc-like central opacification with or without crystals. By the 3rd decade, a dense corneal arcus becomes more common, and by the 4th decade, full-thickness mid-peripheral corneal opacification may develop. Symptoms include reduced phototopic vision, while scotopic vision is usually preserved. Patients may also complain of glare and progressive loss of corneal sensation with age. This slide illustrates the spectrum of findings seen in this condition. In image A, we see central subepithelial crystalline deposits accompanied by corneal haze and the presence of a corneal arcus. In contrast, image B demonstrates central panstromal opacification with arcus, but notably without crystalline deposits, reminding us that crystals are not always present. Finally, image C highlights paracentral anterior stromal crystals with minimal haze and no arcus, emphasizing the variability in presentation. Together, these examples underscore its varying presentation, which can range from prominent crystalline deposition to purely stromal haze, and why relying solely on the presence of crystals is insufficient for diagnosis. Schneider's is fundamentally a disorder of lipid metabolism, leading to the deposition of unesterified and esterified cholesterol as well as phospholipids in the cornea. Histopathologically, these deposits can be highlighted with lipid stains such as oil red O and Sudan black B. On electron microscopy, lipid accumulates within the epithelium, Bowman's layer, and stroma.
In terms of management, the approach follows the same general principles we've already introduced, including PTK, LK, or PKP, depending on severity. A key clinical pearl for SCD, however, is the importance of systemic evaluation. Patients should always undergo a fasting lipid profile, since hyperlipidemia and hyperlipoproteinemia are frequently associated. While treatment of systemic lipid abnormalities with diet or medications is important for overall health, it does not alter the progression of the corneal disease itself. Additionally, because SCD can cluster in families, it is advisable to screen relatives for abnormal lipid profiles.
Now let's review congenital stromal corneal dystrophy, or CSCD. This rare condition follows an autosomal dominant inheritance pattern. Clinically, patients present with diffuse bilateral corneal clouding, often described as whitish, flake-like stromal opacities. The corneas may be thickened, and vision loss can range from moderate to severe. The disease course is usually non-progressive or only very slowly progressive. On pathology, we see separation of the stromal lamellae caused by amorphous deposits. The collagen fibrils are about half the normal diameter, while both keratocytes and the endothelium remain normal. Management begins with correcting refractive errors using glasses or contact lenses. Children may also require amblyopia therapy or strabismus surgery if indicated. In advanced cases, PKP is recommended, though DALK may also be considered. Fleck corneal dystrophy, or FCD, is an autosomal dominant condition that is typically congenital or of early onset and is non-progressive. It is characterized by discrete, flat, gray-white dandruff-like or ring-shaped stromal opacities that often extend to the periphery. Importantly, the epithelium, Bowman's layer, Descemet's membrane, and endothelium are not involved. Patients usually remain asymptomatic, with minimal symptoms and preserved vision. The condition may present unilaterally or bilaterally, though it often appears asymmetric. FCD is associated with decreased corneal sensation and may coexist with other corneal disorders, such as keratoconus, central cloudy dystrophy, or lens and corneal anomalies, and it has also been linked to atopy. Pathologically, vacuated keratocytes containing glycosaminoglycans and lipids are seen, and these deposits can be highlighted with special stains such as Alcyon blue, colloidal iron, Sudan black B, or oil red O. Since vision is generally unaffected and symptoms are minimal, no treatment is required for this condition. Posterior amorphous corneal dystrophy, or PACD, is inherited in an autosomal dominant manner and typically presents in the first decade of life. The hallmark finding is a diffuse, sheet-like, gray-white opacity located in the posterior stroma. This opacity is non-progressive, and most patients maintain relatively good visual acuity, often 20/40 or better. Unlike other stromal dystrophies, PACD is not associated with glaucoma. The cornea in these patients is characteristically flat, with keratometry readings under 41 diopters, and thin, measuring 380 microns or less. This combination of corneal flattening and thinning leads to a hyperopic refractive error. Next, we'll cover posterior amorphous corneal dystrophy, or PACD. This condition has several important associations. It may be seen with cornea plana, often linked to kera mutations. Iris abnormalities are also common, including correctopia, pseudopolychoria, and iridocorneal adhesions. On exam, endothelial indentations from the opacities may be noted, as well as a prominent Schwab's line. From a pathology standpoint, PACD may not be a true corneal dystrophy, but rather an example of mesodermal dysgenesis. This is supported by its very early onset and the fact that it shows little or no progression. Histologically, we see attenuation of endothelial cells and disorganized stromal lamellae located anterior to Descemet's membrane. Management is usually observation, since progression is minimal. However, in patients with significant visual compromise, keratoplasty may be performed to aid in vision rehabilitation. Predecimate corneal dystrophy, or PDCD, is a rare condition with no clear inheritance pattern, though it has been reported across 2 to 4 generations in some families. Onset typically occurs after the age of 30, although cases have been reported as early as 3 years of age. Clinically, it is characterized by focal, fine, polymorphic gray opacities located in the deep stroma just anterior to Descemet's membrane. These opacities may be distributed centrally, annularly, or diffusely. Importantly, the rest of the cornea remains normal and vision is usually preserved. Because of its appearance, PDCD can mimic other corneal conditions, including pseudoxanthoma elasticum, ichthyosis, keratoconus, posterior polymorphous corneal dystrophy, and EBMD. Pathologically, large keratocytes with vacuoles or inclusions containing lipid-like material are observed in the posterior stroma. On electron microscopy, membrane-bound vacuoles and lipofuscin-like deposits can be identified, supporting the view that this represents a degenerative process rather than a classic inherited corneal dystrophy. In terms of management, no treatment is typically required, as vision is well preserved and the condition is non-progressive. We will finish this chapter by discussing the dystrophies that occur at the deepest level of the cornea, the endothelium. These include Fuchs, posterior polymorphous corneal dystrophy, and congenital hereditary endothelial dystrophy.
Fuchs endothelial corneal dystrophy can appear in both early and late onset forms. The early onset type is associated with the COL8A2 mutation, while the late onset type is usually sporadic. In some cases, specific genetic loci are unknown, though TF4 has been implicated, and rarely the condition may follow an autosomal dominant inheritance pattern. Clinically, a typical onset occurs in the 4th decade of life or later, although it may occasionally present earlier. Symptoms are primarily related to corneal edema or the presence of central guttae. Patients often report decreased vision, glare, and reduced contrast sensitivity. These symptoms tend to be worse in the morning due to decreased evaporation overnight, and pain can result from the development of bullae or microcystic edema. The dystrophy progresses through 4 stages. In stage 1, guttae appear in the central cornea and gradually extend peripherally, producing a classic beaten metal appearance. Stage 2 is characterized by endothelial decompensation, which results in stromal edema. By stage 3, patients develop bullous keratopathy, a thickened Descemet's membrane, and increased central corneal thickness, sometimes approaching 1 millimeter. Finally, stage 4 is marked by subepithelial fibrosis, scarring, and superficial vascularization. As the disease progresses, visual acuity declines progressively, making careful recognition of each stage important in anticipating prognosis and guiding management.
When we examine the cornea in this condition, there are a few hallmark findings that stand out. One of the earliest and most important clinical signs is the presence of corneal guttae, which are best visualized with retroillumination, as you can see in the image on the left. These represent localized excrescences of Descemet's membrane caused by abnormal endothelial cell function. As the condition advances, the endothelium begins to take on a beaten metal appearance, shown in the image on the right. This is due to the irregular reflection of light off the abnormal endothelial surface. In Fuchs, the underlying pathology is centered around endothelial cell loss. As endothelial cells are lost, the remaining cells attempt to compensate by migrating and enlarging to cover the defects. This process results in pleomorphism and polymegathism, meaning the cells enlarge and vary in both shape and size. Over time, the overall endothelial cell density decreases, and as function declines, patients develop corneal edema. Another hallmark pathological feature is the presence of collagen excrescences, known clinically as guttae on Descemet's membrane, typically in the central cornea. These guttae are an indication of endothelial dysfunction and are considered a key diagnostic feature. Alongside this, the Descemet membrane becomes thickened, further compromising the corneal architecture. From a clinical perspective, it's important to recognize that specular microscopy is unnecessary when diffuse confluent guttae are already present, since the diagnosis can be made clinically at that stage. While specular microscopy may still be helpful early in the disease or for tracking endothelial cell counts, pachymetry and OCT are generally more reliable tools for monitoring disease progression since they provide quantitative information on corneal thickness and endothelial performance. In practice, an increase in corneal thickness, especially when it fluctuates in the morning due to reduced overnight evaporation, is a clear indicator of endothelial dysfunction. This thickening correlates with worsening posterior corneal elevation and the onset of symptomatic corneal edema. In terms of management, treatment can be divided into medical, surgical, and palliative approaches depending on severity and patient symptoms. Medically, patients are often started on hypertonic sodium chloride drops or ointment, typically 5%, which can help draw out excess corneal fluid. This is particularly useful for reducing the characteristic morning blurring and discomfort that comes from corneal edema. Intraocular pressure-lowering agents may also help, though importantly, carbonic anhydrase inhibitors should be avoided, as they can further impair the endothelial pump function and actually worsen the edema. When medical management is no longer sufficient, surgical treatment becomes the mainstay. The current gold standard is endothelial keratoplasty, specifically DMAC or DSEC, which selectively replace diseased endothelial cells while sparing most of the patient's cornea. If there is significant stromal scarring, however, a full-thickness penetrating keratoplasty may be required. Another evolving option is decimate stripping only, or DSO, sometimes combined with ROCK inhibitors. This is investigational but has shown promise in cases where the disease is limited to central corneal guttae. The principle here is that removing the diseased central endothelium may stimulate surrounding healthy cells to migrate and repopulate, though the clinical course is generally prolonged. Finally, in cases where keratoplasty is not feasible, palliative measures may be used to control pain and improve comfort. These include bandage contact lenses, anterior stromal puncture, amniotic membrane placement, or conjunctival flaps. While these approaches do not improve vision, they can provide meaningful relief for patients with advanced symptomatic disease. When managing cataract surgery in patients with Fuchs, there are several important considerations. In patients with corneal edema, morning increases in pachymetry, or significant morning blurring symptoms, it is often best to perform combined phacoemulsification with intraocular lens implantation and keratoplasty at the same time. Some surgeons, however, favor combined surgery even in the absence of overt edema. If the patient has confluent guttae without edema, cataract surgery alone may sometimes be sufficient. However, in symptomatic patients with extensive guttae and a thickened deciment membrane, a combined endothelial keratoplasty, or EK, should be considered. It's also critical to counsel patients that cataract surgery alone can predispose them to later corneal decompensation, especially if their endothelial reserve is already compromised. Finally, when planning combined procedures, remember that DSEC tends to induce a greater hyperopic shift compared to DMEC, so this difference must be taken into account when calculating intraocular lens power. Stay tuned, as the following 2 slides are videos from the AAO that further discuss Fuchs and phacoemulsification.
These are my financial disclosures. None of them relate to this topic. Pearl number 1, I think it's important to develop a grading scale for the severity of Fuchs. This really assists in discussion for the patient. You can talk about the prognosis of if you did phaco alone, and you could do an excellent operation, but they may get some postoperative glare from the guttata, the risk this patient has of corneal edema, or why you think it's necessary they have a primary phaco and an endothelial keratoplasty. So in this scale, we talk about mild guttata. Really, there's no risk for corneal decompensation in these patients unless you have a very traumatic cataract procedure. But I think it's important because every once in a while, the guttata don't look severe, but the endothelial function is reduced, and there's a very, very slight risk of decompensation. The next stage would be confluent guttata, no evidence of stromal edema. Again, in this case, we would do phaco alone, but discuss the potential need for endothelial keratoplasty, and definitely these patients are going to have some postoperative glare. There is a trend, however, to think about maybe doing a procedure to get rid of the guttata in some of these patients with increased visual needs, and we'll talk about that. And then the next stage is confluent guttata with possible stromal edema, and your charge when you see this more advanced case is to decide if they have edema or not, because if they have stromal edema, you almost always are going to recommend a phaco and endothelial keratoplasty. If it's late in the day and you're not sure, it may be important to bring the patient back for a morning exam because the cornea will look a little bit different in the morning. And then finally, the patient with confluent guttata with definite edema, really there's no reason if the patient has full visual potential with a normal macula and optic nerve just to do the phaco alone, because you'll make the corneal edema worse. Pearl number 2, adjust your preoperative workout. It's important to get a detailed history, and what we're trying to hear is, does the patient have any blurred vision in the morning. You don't want to direct that question. You want to have it open-ended, but blurred vision in the morning that clears with time is certainly a diagnostic typically for decompensated cornea. Endothelial cell count, I think, is the most overused test we see in patients with Fuchs dystrophy. It should not be used to determine whether you do a endothelial keratoplasty or not. We can have patients with confluent guttata, cell count is 0, and they certainly can still do well with phaco alone. So again, don't overuse endothelial keratoplasty. Pachymetry in and of itself should not determine if this cornea is edematous, and I think there is this kind of a historic number of 620 microns or 650 microns that defines edema, but we know from our LASIK workup and the pachymetry we do, we could have very, very thin corneas that can be edematous at 580, and we can have 660 micron corneas that can be non-edematous. So don't use the specific number, but in that patient you're unsure of, pachymetry may help if you bring the patient back for a morning pachymetry compared to an afternoon pachymetry. A difference of 10% can be indicative of corneal decompensation. The slit lamp exam obviously is very, very important. We're looking for subtle signs of corneal edema, posterior stromal folds, stromal haze, and then you can look for epithelial edema. You can touch the epithelium with a cotton tip and see if it's edematous, and that may help you decide whether this cornea is decompensating. Pearl number 3, individualize each patient's visual needs. This will determine the operation you recommend. So general guidelines for patients with stromal edema and any level of cataract or presbyopia, we typically recommend a phaco endothelial keratoplasty procedure. For guttata without edema, we typically recommend phacoemulsification alone, again with the discussion about whether the patient is at risk for corneal decompensation or not. There is, at this meeting, discussions of desmetorexis, and it may be in the future we'll take away those guttata, but for now we typically leave those and just talk about it with the patient. Some exceptions to those guidelines: if the patient has minimal edema, a dense cataract, and maculopathy, they may do fine with phaco alone with residual stromal edema because of the decreased visual potential. And then that patient has stromal edema, but it's pre-presbyopic and no cataract. We're going to do an endothelial keratoplasty alone, and we're not going to take out the lens. Pearl number 4, change your phaco technique in these patients. We want a dispersive OVD. We want to slow down our procedure very carefully, a very good hydrosection to make sure the lens is mobile. We want to, we don't want to prolapse this lens into the anterior chamber, so avoiding supracapsular or flip techniques. We want to use low flow, medium vacuum phaco. We want to minimize the fluid passage along the endothelium, certainly enough vacuum to decrease the need of phaco power, but minimize the turbulence in the AC. So more aspiration, lower phaco time, avoid bevel up phaco techniques, stay in the posterior chamber of the iris plane, again, avoiding high flow and high phaco power in these patients because of the increased risk of endothelial cell loss. Again, for dense cataracts, we want to chop pieces in the bag and remove them under control, work with small lens fragments, reapply OVD if you think the OVD is not in the anterior chamber, not protecting the endothelium. I typically make a slightly larger capsulorhexis so I have a very mobile lens, and then use all techniques to make your surgery easier. Consider a block if you think the patient might be a little uncomfortable, and certainly iris retractors or even moderately small pupils because it will decrease your phaco time. And then pearl number 5, you want to establish a relationship with your corneal specialist. I know my corneal specialist. I know what he's going to tell the patient, but you may not. And I think it's important because you want the same messaging to the patient that the corneal specialist is going to get as you're giving. In addition, the other benefit is that you can learn to know what the endothelial keratoplasty technique the surgeon does. Does he do standard DSEC? Does he do ultra-thin DSEC? Does he do DMEC? And this is important for that question that was just asked because the corneal surgeon will tell you what hyperopic changes they get. And the other real value is that you're going to give the same message to the patient that the corneal specialist is giving. And so if you let the patient find a corneal specialist, he may say to the patient, you should have come to me and had a combined procedure. I don't know why they did phaco alone. Gives the patient a lack of confidence in you, the surgeon. So my top 5 pearls: number 1, develop a grading scale for the severity of Fuchs. 2, adjust your preoperative workout. 3, individualize each patient's visual needs and prognosis. 4, change your phaco technique in Fuchs patients. And 5, establish a relationship with a corneal specialist. Thank you.
All right. Well done, Ed. Right. So, within cornea, endothelial keratoplasty, a big topic. Many of our patients have cataracts, and really, here's a good question. In a patient with a moderate cataract, mild Fuchs dystrophy, 2 to 3 plus cornea guttata, pachymetry 645 microns, would you perform the cataract surgery first and then endothelial keratoplasty later as needed, if and when it's needed, or combined cataract surgery and endothelial keratoplasty at the same time? Question up. Those who want to do separate surgery, cataract first, then later EK, hit number 1. Combined cataract and EK, hit number 2. Timer on, please.
I'm the only one in Zurich doing
Result? Okay, separate surgery, 3/4, and combined surgery, 1/4. Okay, so we have Marion Maxa is going to come up to do the separate surgery cataract first argument. Thanks, Marion.
Thank you, Chris. Thank you, Frank. And the storms a brewing. Cataract first, then EK, or is every guttata an indication for surgery? And I would tell you no. I have no conflict of interest with anything related to this presentation. So in a Fuchs patient, when do you only do the cataract surgery or a combined cataract surgery and endothelial keratoplasty? If there is Frank, as in Frank Price, corneal edema, I think we both agree the answer is a combined procedure. But what if there is no obvious edema? The first question is the following. Is the cornea free of stromal or subepithelial opacities that preclude the success of EK? If the answer is no, consider a corneal transplant first, then do cataract surgery to compensate for the residual refractive error or a staged procedure. But if there's no stromal or subepithelial opacities, then the debate begins. So what are the disadvantages of doing a cataract first, then EK? Well, some would say it's 2 surgeries, and some might say there's a disadvantage of cost of the second operation to the patient, where others might say doing the surgery separately is financially advantageous to the surgeon. But the big argument traditionally has been that trauma to the endothelium is a problem of that patient with guttata, as we see here. But we all know that with modern phacosurgery, viscoelastics now make it very safe to do cataract surgery. So how do you actually sort these 2 things out? It's not rocket science. First, you talk to the patient. Do they have blurred vision in the morning? Overnight, the cornea swells, and this may be an indication of endothelial stress, or as we call it, an endothelial stress test. If they have morning blurring, that's a pretty good sign that they may not do so well with cataract surgery alone. Do they have more blurring in conditions where the pupil is small, such as reading, bright sunlight, eliciting glare or halos? Well, if they don't have a posterior subcapsular cataract, in situations like this may be an indication that the endothelial guttata are a problem. And then you need to know, what are the patient's expectations? Is their pre-op vision 20/40 as the patients that Dr. Price operates on, or 2100 as the patients we see here in Chicago? So when we examine the patient, we talked about looking for frank stromal edema, epithelial edema, and it's always best, if you're not sure, to see these patients first thing in the morning. But I always like to resort to the data. Data will answer the question for you. Handheld pachymetry is not always reproducible due to the time of day or centration. An orb scan or pentacam can give you a lot of information. You want to know if that central pachymetry is equal to the paracentral pachymetry or greater. Anterior segment OCT, endothelial cell counts, and confocal microscopy can also be used. Recently, I have to get up on my tiptoes so I can see these slides. Recently, in ophthalmology in 2014, there was a great study done looking at 89 patients with Fuchs endothelial corneal dystrophy. Oh, thank you. Oh, I'm so much taller now. Okay. And what they found is that the central corneal thickness and backscatter at the basal epithelial cell layer, called EV, using confocal microscopy, can predict which patients will fail after cataract surgery. The numbers you need to remember are 1894 for the EV and 630 microns for central corneal thickness. They demonstrated 94% specificity and sensitivity. So, what should you do? Talk to the patient. Talk to the patient. Look at the patient. See the patient in the morning. Check the data. If you have a confocal, great. But if you don't, look at the central corneal thickness and look at a tomography of the cornea with either orb scan or pentacam or your technique of choice, and look at the central corneal thickness compared to the paracentral corneal thickness. And remember that cost is an issue for some patients and doctors. Thank you so much for your attention.
Thanks, Marianne. Okay, time for Frank Price.
Okay, thanks. Like Marion, we hadn't seen that question. I was assuming these were people without edema. No relevant disclosures.
Just the facts, man.
And I think in this debate, we want to recall that advice and just stick to the facts. So what are the facts? Combining or not combining cataract surgery with EK is on the expected results. Is one way safer? Does either way provide superior results, like cost savings, or is it more convenient for the patient and their families? Now, there have been multiple reports, there's 3 here, about how DALK can routinely be combined with cataract surgery without any significant effect on outcomes. And we had early concerns doing DALK with combined cataract surgery because of leaving the viscoelastic there. Is that going to be a problem? Would we have problems with the instability of the lens as we move the pressure up and down to unfold the donor, and would that damage the donor? And how do we modify our surgery if we do combined procedures? With the MEC alone, there's no viscoelastic. We use air to strip decimase. And if it's with phacoemulsification, then we strip with viscoelastic, evacuated, and use myostat to constrict the pupil. Otherwise, the procedure is the same. Either way, it's outpatient, topical anesthesia, small incision. So we looked at 550 DMEC cases. 345 were DMEC single, 205 were DMEC with cataract extraction and IOL. No difference in graft success, air reinjections, endothelial cell loss, or vision improvement. So what are the implications? Combining DMEC with cataract surgery had no increased risk compared to DMEC alone. It's easier for the patient, less expensive for both the patient and the healthcare system. We've even reported now on doing rapid sequential DMEC and cataract extraction, where these people have their 2 eyes done a week or 2 apart. And we're not operating on 20/40 eyes all the time. A lot of times the second eye is 20/20 or 20/25, but the patients notice their vision's really poor in that eye and they want to have it improved. So the question is, what's more important, Goutte or edema? So we structured this where these were eyes without edema. And our experience with DMEC is that the Goutte do matter. You shouldn't wait for edema. If you wait for edema, that can lead to possible loss of stromal tissue and long-term degenerative changes in the anterior surface of the cornea, and Sanjay Patel has reported on that. Now, I want you to look very closely at this. If you do decimase stripping, you may have noticed this with combined procedures. It's a relatively clear cornea, probably 20/40, 20/30 in the Snellen acuity, but look at how much clearer it becomes as we strip off decimase. In fact, where decimase is double or triple thickness, you begin to see it's not clear. Decimase isn't clear in Fuchs patients. It's actually opaque, and the Goutte further diffract the light and cause distortion of the vision. So if they're confluent Goutte, patients are not going to see clearly without glare until you do EK. So the question's not if you should do these combined or not. The question is if there's enough Goutte to distort the red reflex, then they should really have EK performed. And then the question is there cataract bad enough to take out? So the obvious choice is to do DMEC and combined cataract. Thank you.
Marion, 1 minute.
Okay. Well, the question is about cataract surgery and a patient with guttata. So it can be very difficult to get that red reflex because where I come from, we usually wait till the patient has a cataract that we can see at the slit lamp, and the cataract alone will decrease your red reflex, making it really difficult to determine about the endothelium and its effect. So I guess I just don't quite have the chutzpah of Dr. Price to be operating on these 20/20 and 20/25 eyes. And when someone truly has a cataract that I can see without clinically significant corneal edema, I say 20 happy is what I'm going for. And if 20 happy means one surgery, no EK, no long-term steroids, I'm going just for the cataract, and I hope you'll go with me.
Thank you. Frank, 1 minute.
I have a couple extra.
Sure. Couple slides.
No, as we finish up here, you know, the question is that people can actually see a lot better. And just because they might be satisfied because they don't know what they can actually see doesn't mean that's what we should do. I think modern phaco has shown us that you can operate on people that are 20/20 and 20/25 with PSC cataracts and markedly improve how they do. And so when we make these choices, it depends upon the tools we have. So when we're doing cataracts and grafts, it depends upon which type of graft we're going to use. But what I would like to do is make this, I'm not advancing for some reason.
Advance the slide, please.
So I want to make this easier to understand. I'm going to become more basic, or we'll say primitive. And let's just think about if we're making a decision between if we're going to fight or flight, fight or run. And so we have a couple primitive people living out in the jungle. And a bear comes up. And so are you going to run or are you going to fight? And it depends upon your tools. Now, if you each are armed with a stone knife, I think you're going to run. If you have a spear, you're probably going to throw your spear and run. If you got an automatic weapon, you're probably going to fight. And I'd say DMEC is the automatic weapon that allows us to do these combined reliably. So combined surgery is the obvious choice. Patients prefer one surgery. It's less cost. Vision's not clear until you get the guttae out of the way. And DMEC makes it possible. Thank you.
Thank you very much. Okay, audience voting. Get the ARS back up. Okay, number 1 for Marion, cataract surgery first, then EK if needed. Number 2 for Frank's combined cataract surgery and EK. Turn the timer on, please. Okay, so Frank turned some opinion here. Okay, great job.
Now let's move on to posterior polymorphous corneal dystrophy, or PPCD. This condition is most often autosomal dominant, though it's worth noting that rare, isolated unilateral cases have been reported, and overall the hereditary pattern is not always consistent. In terms of clinical presentation, posterior corneal changes are the hallmark. These can include isolated endothelial vesicles, geographic gray lesions, and broad scalloped endothelial bands. Some patients may also demonstrate stromal edema, keratopia, or broad iridocorneal adhesions, which can occasionally be detected as fine adhesions on gonioscopy. Importantly, PPCD is not just limited to structural changes of the cornea. It also carries a significant association with glaucoma. About 14% of patients develop elevated intraocular pressure, either in the form of chronic angle closure glaucoma or primary open-angle glaucoma. In the image on the right, you can see clusters of endothelial vesicles under broad oblique illumination.
They're often grouped together, giving a blister-like appearance on the corneal endothelium. The hallmark pathological feature of PPCD is that the endothelial cells look and behave more like epithelial cells or fibroblasts rather than their normal phenotype. This is supported by features such as microvilli, rapid and multi-layer growth and culture, keratin staining, tight junctions, and even proliferative tendencies. The decimate membrane is also abnormal, often showing thickening, a multilaminated appearance, and polymorphous changes. On confocal microscopy, PPCD presents as vesicles, bands, and irregular railroad track patterns. Management depends on severity. Many patients remain asymptomatic. For those with mild edema, management can mirror that of early Fuchs, hypertonic saline, and monitoring. Localized swelling may be treated with anterior stromal puncture to induce focal subepithelial fibrosis. In more severe cases, keratoplasty may be required, though prognosis worsens when synechiae or glaucoma are present. Recurrence is possible in grafts, and endothelial keratoplasty is preferred in cases with limited stromal opacification, rather than a full-thickness keratoplasty. Usual glaucoma management applies when intraocular pressure is elevated. Finally, the differential diagnosis includes ICE syndrome, but PPCD is usually bilateral and less aggressive. It can also mimic congenital corneal opacities. In PPCD, one of the characteristic findings is the so-called railroad track or snail track appearance, as seen in the image on the left. This results from abnormal endothelial cell behavior. Instead of functioning as a stable, non-proliferating monolayer, the endothelial cells transform and start behaving like epithelial cells. They proliferate, migrate, and lay down abnormal multilaminated basement membrane material. This excess basement membrane deposition organizes into long band-like opacities along the posterior corneal surface. When light reflects off these parallel ridges and clear zones, we see the classic track-like appearance under the slit lamp. Essentially, these snail tracks are the clinical manifestation of abnormal endothelial proliferation combined with disorganized basement membrane production. The image on the right depicts the iridocorneal adhesions that can form, which can result in correctopia. Lastly, we'll look at congenital hereditary endothelial dystrophy, or CHED. CHED is inherited in an autosomal recessive pattern. Historically, there were two types, CHED1, which was autosomal dominant, and CHED2, which was recessive. CHED1 is now considered part of PPCD, so when we talk about CHED today, we are referring to the recessive form, formerly known as CHED2. The clinical presentation is congenital, non-progressive corneal clouding due to stromal edema. The appearance can range from a diffuse haze to a more dense ground glass look. This condition is present from birth or infancy, and the cornea is markedly thickened, often 2 to 3 times normal thickness. Importantly, it is rarely associated with elevated intraocular pressure, which distinguishes it from congenital glaucoma. Symptoms include blurred vision and nystagmus. Unlike other congenital corneal disorders, like congenital glaucoma, CHED does not typically cause significant tearing or photophobia. One important clinical pearl: stromal edema helps distinguish CHED from congenital hereditary stromal dystrophy as well as from congenital glaucoma. So when you see a thickened, edematous cornea with early onset haze and vision loss, CHED should be high on your differential. On pathology, we see diffuse thickening and lamination of decimates membrane. The endothelial cells are sparse and atrophic, often containing vacuoles. Under electron microscopy, there are multiple basement membrane-like layers on the posterior aspect of decimates membrane, which reflects degeneration of the endothelial layer. Severe stromal thickening and lamellar disorganization are also characteristic findings. When it comes to management, severe edema typically requires corneal transplantation, either penetrating keratoplasty or endothelial keratoplasty. The challenge, however, is that prognosis may be limited by amblyopia if the disease is not treated early, especially in children. This emphasizes the importance of early recognition and timely surgical intervention.
Congratulations! You've made it through the entire chapter on corneal dystrophies. We've covered the major categories: epithelial, stromal, and endothelial dystrophies, along with their inheritance patterns, clinical presentations, pathology, and management strategies.
A few big take-home points to remember are that most are inherited in an autosomal dominant fashion, many share similar management principles such as superficial keratectomy, PTK, keratoplasty, and careful follow-up, and that subtle clinical clues like honeycomb patterns, lattice lines, guttae, or rail track appearances help distinguish between them. Excellent work finishing this section! Following this, there will be a 10-question quiz that you can